Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Everyone is touched by psychiatric conditions, either themselves or a loved one. Do not suffer in silence. With help, there is hope. Today on Healthy Minds.
If somebody has the misfortune to develop schizophrenia now, they're in the best situation of anybody in human history to get effective treatment that can alleviate their symptoms, and if it's instituted early enough and effectively, can really halt the illness in its tracks and prevent what has been the historically chronic morbidity and disability associated with the illness.
That's today on Healthy Minds. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, and the New York State Office of Mental Health. Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. How does a person with schizophrenia regain their health? Today I speak with leading expert Dr. Jeffrey Lieberman about the most cutting-edge treatments for schizophrenia, including medications, psychotherapy, cognitive remediation, and case management. Jeff, thank you for joining us today.
Pleasure to be back with you, Jeffrey.
I want to start off by talking about the state of the art. Where are we with regards to treatment for schizophrenia?
Well, it's a mostly good news story in the sense that if somebody has the misfortune to develop schizophrenia now, they're in the best situation of anybody in human history to get effective treatment that can alleviate their symptoms, and if it's instituted early enough and effectively, can really halt the illness in its tracks and prevent what has been the historically chronic morbidity and disability associated with the illness. And basically what we've learned is that over the years, as studies have been done to develop pharmacologic treatments, psychosocial and rehabilitative treatments, that these things are most effectively used when they're combined, psychosocial with pharmacologic.
Medicine and talk therapy, other forms of therapy together.
That's right. And administered as early as possible after somebody shows signs of developing the illness. And this has been really codified in what's called the early identification intervention strategy. And it basically consists of a series of evidence-based treatments that have now been proven by numerous studies. On the pharmacologic side, we've had antipsychotic drugs, which provide the cornerstone of the treatment for schizophrenia now for several decades. And although we're still using drugs that have the same mechanism of action, meaning they bind to the dopamine 2 receptor, they inhibit the effects of dopamine stimulating the postsynaptic neuron, that succession of the newer medications, they retain the efficacy or even optimize the efficacy, but they minimize the side effects. And although the new medications aren't without side effects, mainly the ones that are most problematic have to do with weight gain and metabolic effects on glucose and lipid metabolism. These are very tolerable and highly effective, many different versions of these, long-acting, injectable, available also. So when someone says to me, I can't take any medication because they all have terrible side effects, I know that can't be true because there's enough options with different permutations of side effects and dosage potency that you should always be able to find a tolerable and effective medication for people who need antipsychotic medications.
The right match for the right individual, and even if they have some side effects, being careful about the exact dosage and sometimes even giving some medicine to fight off those side effects.
That's right. And a key principle to keep in mind both for patients and family members as well as doctors is you can't settle. In other words, if somebody gets somewhat better, you can't just settle for that. You have to try and alleviate as much or all of the symptoms they have and achieve a dosage or a medication that is not something they're going to have to endure uncomfortable side effects for indefinitely.
And on the therapy side, what types of things are available now that might not have been used previously?
Well, I think here is really where the most innovation has occurred on the psychosocial side. And we have an array of services that should be standard, available everywhere, and reimbursed by third-party payers. Fortunately, they're not, but we'll get to that later. But these include supportive psychotherapy, something called supported employment or education. So when you have a psychotic episode, you're hospitalized or treated, your symptoms abate, you begin to resume your normal activities. Even if your symptoms have subsided, you're not necessarily ready to jump back into action by returning to college or going back to the job. It's like, if you're an athlete and you're playing tennis or basketball and you get injured, you recover, but you don't necessarily get back.
You need a little time of rehab before you get back to where you might have been.
Exactly. And so supported employment, supported education are basically giving you that support so you can become reacclimated to what you were doing and not jump back into it, fail, and then feel, like, you're not over your illness or you're not going to be able to do what you used to be. At the same time, there's also practical things in a person's life that frequently have to be negotiated, like how do I get insurance payments? Do I need to apply for Medicaid? How do I find a place to live? Prior living arrangement isn't viable. So this is case management. And then you also have issues having to do with, okay, my symptoms, my hallucinations, my delusions, my thought disorders may have improved, but cognitively I'm not as sharp as I used to be, or the medication may be limiting me. There's now an approach called cognitive remediation, which are largely computer-based exercises you go through, which really sharpen all of your different cognitive functions. And then finally, the rehabilitation treatments of social and vocational rehabilitation, which enable a person who's undergone really a kind of soul-shaking kind of illness that they had no idea they were susceptible to and now recovering from, how do I get back into the social swing of things? Begin socializing, meeting other people, dating, and so forth. And then if I'm, want to get a job, so this helps you do that. And what we've learned is that it's the combination. Not everything is needed for everybody, but some combination is. And combining these things, it's really the whole is greater than the sum of its parts when this is done.
In many ways, the cognitive, the social, are getting help in those areas are even more important than taking care of the hallucinations and delusions, because to move forward with one's life, you really need to be able to have those cognitive and social abilities as strong as possible.
Right. They either address what medications aren't effective in treating, or they augment what medications have begun the process of improving. And then also, we know that individuals who have schizophrenia, have a first episode or a relapse from an exacerbation of their chronic illness, that oftentimes they're susceptible to complications of the illness. So by that I mean substance abuse, depression, post-psychotic depression, or suicide. And so it's a program that offers this kind of array of treatment services and needs to also have the ability to have substance abuse counseling or treatment where needed. Be aware of the fact that post-psychotic depression is common and antidepressants may need to be introduced, and also be on the lookout for signs of suicidal ideas, because this is something that does occur at an increased frequency in people with schizophrenia, and particularly in the earlier years of the illness.
Now, you spoke about the early identification. I'd like you to speak a bit about what's referred to as the prodromal phase, where somebody has not had a full diagnosis of schizophrenia, but may be at risk. And what should people know about that?
Well, this is really where I think the greatest innovation and excitement comes, which is the ability to really stop the illness before it does great damage. Historically, the notion about schizophrenia was a fairly pessimistic one, that you were kind of doomed from the womb. And if you got the illness, it was an inexorable kind of downhill course, like people who have Alzheimer's disease. What we've learned in the past 2 decades of research is that people at the beginning of the illness are highly responsive to medication and treatment. They can achieve symptom remission and, with the appropriate psychosocial supports, recovery. So the whole key is getting to people early, because the longer a person is actively sick before that first treatment is introduced, the less their chances of recovery and the poorer their prognosis. And then when surveys have been done about people who have recovered from a first episode, saying, well, looking back, when did your symptoms first begin? Turns out that the average duration is like a year. This is with psychotic symptoms. It's not like if you have chest pain, or stomach ache, or you break your leg, where you immediately know where to go and what to do. It takes time before this people are aware of this and it impacts on them. So reducing this duration of untreated illness is an important thing, and the best approach there really has been kind of public education and awareness.
What type of symptoms should a person be aware of in themselves, or a person be aware of in a loved one, that might be a sign of this prodromal period?
Well, there's a notion called mental health first aid, which has become popular now, which is kind of addresses that in a formal way. And basically, one of the problems of trying to identify people who are developing schizophrenia early, in as you alluded to before, the so-called prodromal phase, is that the behaviors and these mental signs that are associated with this are nonspecific, and they're things that are not uncommon with teenagers or young adults that are maturing. And so what I mean is that the characteristic so-called beginning early warning signs of the illness have to do with having kind of a change in the nature of your thoughts, becoming more preoccupied with certain things like the occult or religion, or getting obsessive into some kind of heavy metal music, but this is what a lot of teenagers are doing anyway. So it's very nonspecific. Or you have a change in your ability to concentrate, to pay attention, your moods become more volatile or mercurial. You lose interest in things you've had, your grades drop in school, you stop associating with the friends that you do. So these are things that, in retrospect, after somebody's become sick, are very commonly seen, but they're also commonly seen in people who never become sick. So that's the non-specificity. Nevertheless, what researchers have really targeted is the fact that, well, if we know that treating people at the beginning of their illness can improve recovery and long-term prognosis, and we know that people don't get sick overnight. They get ill in a kind of a gradual or iterative fashion over weeks or months. We got to identify them there, the prodromal stage. The question is how can you be certain that what you're observing and what people are experiencing is really the beginning of an illness, or it's just a phase they're going through?
An important message for family members, or if you're concerned about your child, better to look at it, get an evaluation, and then be able to carefully monitor it.
Absolutely. I mean, my advice to people is err on the side of caution. In other words, if somebody's complaining, oh, I have a stomach ache, or my shoulder hurts, or I'm having difficulty breathing, you pretty much react to that and advise them, accordingly. Somebody's, not feeling well, not acting the same, showing a change in the things they're interested in, saying things that are seemingly peculiar. Most people don't necessarily do anything, and even if they are concerned, they don't feel it's their place to sort of intercede. And I say, why not? Why not? If somebody's, choking, if somebody's turning red, if somebody's fainting.
Any physical thing, people would right away intervene.
Right, and so what's the worst that people can do? Say, mind your own business, or it's nothing, nothing important, don't worry about it. But, you may be helping them. And so when you see changes, whether it's a family member, a friend, a colleague at work, show interest and say, I've noticed this has been happening. Is anything that is of concern or causing a problem? Maybe just point them in that direction, and that I think is helpful in terms of showing compassion, but also directing them to seeking at least evaluation, if not help for that, which is something that takes far too long for people to do under the current situation.
You said earlier on, I think it's an important statement, that, well, obviously nobody wants to have any illness. If somebody's going to have schizophrenia, now is a better time than years gone by. What do you see as the future? What's the hope for even better care for people and potential methods of prevention and cures and treatment?
Well, everybody's looking for the cure for an illness or something that can be administered even before it begins to prevent its onset. And here, I think we've been to some degree stuck with respect to identifying new biologic targets to develop treatments for. So the holy grail for the treatment of schizophrenia has been and still is the dopamine 2 receptor. There's been an intensive effort to identify other molecular entities to develop medications to target, or even to use before people become ill if they're, let's say, they have first-degree relatives with schizophrenia and thus are at greater risk. And there we haven't been that successful at breaking through yet. Now, to some degree, that's put us in what I call the catch-22 of psychotropic drug development, which is that because of the challenge of being able to identify these novel biologic targets, the NIH is divested. The treatment research that the NIH is funding in schizophrenia or all mental illnesses has been diminished, and pharmaceutical companies have kind of retreated because it's been high gain but high risk. And so how are we going to innovate if there's not the investment? So I see that as a problem, but nevertheless, the genetics studies that have been done and affecting all of medicine, beginning with cancer, particularly cardiovascular disease, but also brain disorders and mental illness, are providing clear evidence of a gene or group of genes associated with disease susceptibility. These genes all produce proteins that are potential targets for therapies, and then allowing development of medications targeting those as possible treatments. That's a very powerful strategy that I think is going to produce transformative, if not miraculous, treatments. The limitation, though, is that it's going to be like peeling the diagnostic onion, therapeutically speaking, meaning that when you identify somebody who has schizophrenia, you genotype them, you find a mutation that has a large effect and is believed to be associated with the illness. That gene produces a protein that you never would have thought of using an antipsychotic drug or anything else for, and it suggests a treatment, and you use it, and it works. It's only going to apply to like 2, 3, 4, 5% of the people.
Because what we call schizophrenia is probably schizophrenia A, B, C, D, E, and F. It's not just one simple illness in the way you're describing.
Yeah, this basic approach is called precision medicine, and in this case, precision psychiatry. And the analogy is like if you have congestive heart failure, if you have pneumonia, this is the syndrome, i.e. what schizophrenia is, but the etiology of your CHF and of your pneumonia can be different, and your treatments for that are going to be different. So we're going to be able to really target treatments more specifically. They'll be more effective, but it won't apply to the whole range of people. And pharmaceutical companies, although this will drive their innovation, it'll also impact their business strategy because the potential market for the treatment won't be the entire world's population of people with schizophrenia. It'll only be those that have this particular genetic profile.
Then again, it potentially could be so effective that that market is worthwhile for them, obviously worthwhile for the people who receive the medicine.
The other thing that I think is really going to be, and this is within our professional lifetimes, and hopefully sooner than the next 5 to 10 years maximally, I'm confident we're going to have diagnostic tests. So as you know, mental disorders is a group of illnesses that's probably unique among all human conditions that doesn't have diagnostic tests.
A blood test, a brain scan, some other lab test.
Right. I mean, we have no EKG to define depression. We have no blood test to identify schizophrenia. But I think that this is really coming, and particularly using the modalities of neuroimaging with magnetic resonance imaging. And the first place I think this will be applied is in schizophrenia in the so-called prodromal phase. Because if you see teenagers or young adults who are experiencing these non-specific types of behavioral or mental function changes, but there's a high degree of false positivity, you then do a diagnostic test, in this case a functional MRI procedure, that can specify who among those are within the ensuing year or so are going to develop the illness.
So that through research we would be able to know people have a set of symptoms, but then a certain type of finding on the functional MRI, those are the people who are more likely to go on to develop the illness and therefore should receive the intervention before then. Just
like, if you're experiencing chest pain, your doctor's not going to immediately do a catheterization or put in a stent. They're going to do an EKG, or maybe they'll do an exercise stress test. It could be GERD, it could be pulmonary embolus, it could be a musculoskeletal thing. So this is something that will, I think, both give psychiatry and mental disorders more credibility, street cred with the public, because they'll say, oh, you can really see something. And also it'll provide this greater degree of diagnostic precision.
Right now, for family members who are concerned about their loved one, they may have the diagnosis already, and maybe they're not doing as well as they would hope. What should they do?
I think that there's tremendous room for improvement without even if we never learned another thing about the nature of the illness, the cause, or developed any superior treatments, we can do so much better for people. It's like we're fighting a fight with one arm tied behind our back.
We're not using all the tools that we currently have.
Right. People, one, lack awareness to know that there are effective treatments, and whatever they're getting, there may be much more that's available. Two, they lack ability to gain access to it, either because it's not available geographically in their area, or the insurance coverage that they have doesn't support it. And I think this is directly the result of our healthcare policies and financing system, which has not made the best available to everybody. So the analogy that I sometimes use is that imagine if you had breast cancer and you went to the hospital and they diagnosed, oh yeah, you've got a lump there, did a x-ray and biopsy, yes, and you need to have a lumpectomy, you need to have chemotherapy, you need to have radiation. I said, but we can only do the lumpectomy. That's the situation we're in with schizophrenia. So what it means for family members is that, one, you don't settle.
So you have to really advocate for your loved one.
You have to advocate, and you have to find where you can get access to the best treatment. And then figure out how it's going to be paid for. If your insurance company doesn't pay for these things, supported employment, psychotherapy, cognitive remediation, you have to find out why. And you, as we know, you frequently have to sort of, it's a test of wills between you and your insurance company as to what they're going to reimburse.
Don't give up. Don't
Exactly.
give up.
Exactly. It shouldn't be this hard, but it is. But the good news is that there's effective treatments out there. The less good news is that you often have to work or fight to get them.
Jeff, I want to thank you for the research you've done, the leadership that you've provided to our field, for our profession, for patients and families, and thank you for again joining me here today.
My pleasure, Jeff.
The key take-home message about schizophrenia is that people benefit from an array of treatments, not just medication, but also psychotherapy, cognitive remediation, case management, and others, as well as the support of family and friends. And never give up. If one type of treatment is not working, try something else. Remember, with help, there is hope. Until next time, I'm Dr. Jeff Borenstein. Goodbye. Do not suffer in silence. With help, there is hope. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, and the New York State Office of Mental Health. If you would like to watch our expert interview in its entirety, log on to bbrfoundation.org/healthyminds.